Okay, I'm now live. I'm trying to do my desktop, but it wasn't working. My laptop, right there, my MacBook, and it kept spinning. So I went to the desktop. So here I am. Hello, everybody. It's Tuesday, February 12th. Hope everybody's doing well. It's a little less cold than it was last week, and that's great for everybody. And hopefully, I looked at the charts. It's going to stay actually warm. So real quickly, this talk is on CT of lymphoma. And one of the things we know is lymphoma is one of the common pathologies that we all look at. We stage lymphoma, we detect lymphoma, we follow up lymphoma. Lymphoma is a great mimicker. Remember, it involves every organ. If you think about lymphoma and you just describe it, you say you're looking for adenopathy. You're looking for adenopathy in the chest, in the abdomen, periaortic region, pelvis, you name it. But lymphoma also involves many other things. So, for example, I gave a conference yesterday, and I showed a couple of cases of lymphoma involving the pericardium. I also showed cases involving the chambers themselves, the right ventricle and also left ventricle. I showed a great case of infiltration of the left ventricle as well as infiltration of the kidneys. When you think about lymphoma, you also think about the abdomen. We just published a paper on CT of lymphoma. And we showed that it can be solitary lesions, multiple lesions, solid mass, diffuse infiltration of the hilum. It can look very much like cholangiocarcinoma. We're doing an article on lymphoma of the pancreas where it could be diffusely infiltrated, look like autoimmune pancreatitis. It could be a solid mass looking like a pancreatic cancer, or multiple lesions looking like metastatic disease. So it's a range of appearances. We talk about the spleen. You can have multiple lesions in the spleen, which kind of looks like sarcoid. Splenic alone is possible primary splenic lymphoma, but often you'll have involvement of the kidneys or the liver as well. We've written an article in the past year about a primary adrenal lymphoma. Big bilateral adrenal masses tend to maintain the adrenal shape, is a classic appearance, but it's typically going to be bilateral. We talk about renal involvement, solitary mass, multiple masses, perirenal extension, periaortic extension, solitary or involving the one kidney or involving both kidneys. We talk about bowel infiltration, masses which can intussuscept, masses which infiltrate long segments of bowel, often without obstructing. We talk about colonic involvement. We talk about bone involvement, can be sclerotic lesions or can be lytic. We talk about adenopathy, typically soft tissue density, unless it's treated. If lymphoma is treated, then the nodes can become cystic, the nodes can calcify. Again, PET can be very helpful if you're looking at viability of nodes, because sometimes nodes get smaller on CT, but you can't really tell is there any viable tumor, and PET can be helpful in that regard. So when you think about it, lymphoma is involving every organ, so you need to always think about it. The other tumor that, when I show conference cases, and you're trying to think about things, you got to mention melanoma. Melanoma and lymphoma have a lot of things in common. They're both common tumors, and both of them involve multiple organs. Again, melanoma, liver, spleen, kidneys, adrenals, the heart, the lungs, bone, you name it. And of course, both of them, I don't do anything from up here. I mean, I think, but that, I mean, you know what I mean. If you're doing neuro, then you're looking at lymphoma of the brain. You're looking at melanoma metastatic to the brain. So all of those are indeed possibilities. So in terms of protocols, usually venous phase imaging alone is enough. Sometimes the kidneys, you might want to do some delayed phase imaging as well. You never could go wrong with dual phase imaging, I will quite admit. If you only do non-contrast, you'll miss a lot of pathology. You might see the organs look big, but you're typically not going to see what you need to see on the non-contrast scans. Now let's see, I'm trying to see who's here, if anyone, viewers. Now most people will be seeing this talk at a different time because everybody is probably working now. So I'm trying to find how I can see the current viewers. We got a bunch of them, but I really can't see them. But anyway, I'm happy you are here. And then a lot of people will be looking at the things later on because that's typically the way things go. These days, everybody, it's convenient, the ability to look at things when you want to look at them. So that becomes very, very important as well. So with that, I think I'll stop there. That's kind of a good look at lymphoma. Look at CTisus, you'll see a lot of cases. There were some lectures I gave. We just posted a lecture. Actually, I just gave it yesterday, so it'll be a few months till it's posted on the cinematic rendering and its role in small bowel tumors, including lymphoma. We did publish that article I mentioned. You can look it up on adrenal lymphoma. And we've published a lot on other areas as well within lymphoma. And you can see those on CTisus and look at a lot of cases. And there's some lectures that I've given specifically on the topic. So with that, I hope everybody has a great day. See you later. Keep warm.